Hello everyone and welcome back to our series, Person-Centred Care in Practice. My name is Anna Flynn and I'm the Director of Partnering with Consumers at the Australian Commission on Safety and Quality in Healthcare. I'm delighted to be bringing you today's presentation, Inclusive Healthcare for People with Intellectual Disability. But before I do, I'd like to pay respect to the Gadigal people as the traditional custodians of country where the Commission's office is located. I extend that respect to all Aboriginal and Torres Strait Islander people and their deep time connections to land, water and sky. So we're running this webinar today to coincide with International Day of People with Disability. And I think the tagline, "Be part of creating an inclusive and diverse community in Australia," sits very nicely with the presentations that we have for you today. The Commission has a number of resources available to support health services to embed inclusive healthcare for people with intellectual disability, and they're available on our website. These include a standards user guide for the healthcare of people with intellectual disability, which was developed to support health service organisations and clinicians in providing safe and high quality healthcare to people with intellectual disability. There are also 3 fact sheets associated with the user guide, which we have just translated into EasyRead. We have our 4 steps to inclusive healthcare, With Me and About Me, which includes a range of posters and fact sheets to support consumers and clinicians in providing safe and inclusive healthcare for people with intellectual disability. We also have information on making reasonable adjustments in EasyRead and an Easy English version of the Australian Charter of Healthcare Rights. A quick reminder about our Person-Centred Care Resource Hub, where you can find all things person-centred care, including recordings of past webinars, case studies, newsletters, and information about our Person-Centred Care Network, which has grown to over 6,000 members. Right, we have a jam-packed session today with 2 presentations followed by a live Q&A session. Our first presentation is from Dr. Kathy Franklin and her assistant Katrin Kuller. Kathy and Katrin will demonstrate some practical examples of small adjustments that make a big difference in making people safe at their clinic in Queensland. Then we'll hear from Dr. Jessica Smith, who will talk about some groundbreaking person-centred interventions that can help people meet their health goals by meeting people where they are at. After that, we'll have a live Q&A where we'll be joined by Ricky Kremer, Lived Experience Inclusion Lead, and Professor Julian Troller from the Centre of Excellence in Intellectual Disability Health. So, without further ado, over to you, Kathy and Katrin.
Hello everyone, my name is Katrin and I'm a research assistant here at QCEDA.
In the spirit of reconciliation, QCEDA acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders, past, present and emerging. We also recognise the contributions and the expertise of people with intellectual disability and those on the autism spectrum, and are committed to their meaningful inclusion in all aspects of our work. Their insights shape our clinical care, research, and education. We honour those who have suffered premature or preventable deaths from inequities in the health system and work to ensure others are not left behind.
Okay, so I know going to see a doctor can be stressful, but today we're going to tell you about some things that we can do to make visiting our clinic less stressful.
Hello, my name is Dr. Kathy Franklin. I'm a psychiatrist and the director of QCEDA. Yes, Katrin, it can be stressful, can't it? Sometimes people remember that they were stressed here at hospital in the past, and that can make them scared too. Our clinic at QCEDA is in a hospital. There are lots of things that we cannot change, even though some of them we would really like to. Today, we will tell you about the things that we have changed and the things that we would change if we could.
So we're going to start with what happens before people have come into our clinic.
Before coming to clinic, our nurses have a phone appointment with the patient and or their family or support people. In that appointment, we find out if people will need extra help when they come to our clinic. If the person prefers to have a telehealth appointment, we can do that. but we really do like people to come if they can. Some of our patients can't even come into the building. It is too stressful. So when we find out that on the phone call, we make arrangements before they come to see them outside the hospital building, maybe in the garden out the back in this picture, or even sometimes inside their car in the car park. Sadly, we don't have enough funding for our clinic to visit people at home, because that really would be best for some of our patients. Most of our patients with intellectual disability and our autistic patients also need a longer appointment time. So we make sure before they come that they have 1 hour appointments or a 30-minute appointment if that's all they need.
So we would like to tell people that we have a website of our own. And this website is in plain English and has an easy read version, so you can see by clicking the box on the web page. We also like to send people a video of how to find a clinic and what to expect when coming to see us. So we're going to have a look at that video now.
Hi, I'm Katrin. I'm a research assistant at the Queensland Centre of Excellence in Intellectual Disability and Autism Health. We call it QCEDA for short. At QCEDA, we run an outpatient clinic at the Marla, exclusively for people with intellectual disability and autistic people. Today, I'll show you around the clinic. I'll explain what to bring to your appointment, how to get to the clinic, and what to expect during your visit. So to make an appointment for our clinic, you need a referral from your doctor. On the day, bring your Medicare card, a concession card if you have one, your health passport, and any reports from your health workers. You'll find our clinic on level 4 of the 7 building at Marla Hospital, Brisbane. It's on Sterling Street at South Brisbane. There are a few ways you can get here: by car, by bus, and by train. If you're arriving by car, the best car park is Mother Hill Car Park P4. You can enter this car park from Stanley or Water Streets. It's best to park on level 3 or 4, then take the lift to level 1. Exit onto Stanley Street and cross the lights to the 7 building. If you're arriving by bus, get off at Mother Hill bus station. It's also across the street from the clinic. If you're arriving by train, walk along Stanley Street from South Bank Station. Once you enter the 7 building, take the lift to level 4 and check in for your appointment at the front desk. There are bathrooms on this level 2 just behind the lift as well. You'll find a clinic in corridor 4. After checking in, take a seat in the waiting area in corridor 4, and our nursing team will call you when it's time. Our clinic is led by Dr. Kathy Franklin. She's a psychiatrist and expert in intellectual and developmental disability research and healthcare. She's joined by other psychiatrists, Dr. James McAuliffe and Dr. Melanie Johnston. Our GP, Dr. Matt Kahneman, our psychologist, Dr. Kate Ropanoff, and our nurses, Sona, Kathy, and Amy, and more health professionals who are all here to help you. When it's time for your appointment, you'll see the doctor in the consulting room. Appointments will run for up to an hour. You're welcome to bring someone with you. You may have your blood pressure, weight, and height recorded. And you might see other health professionals during your visit. If you have any questions about visiting the clinic, please call us. We look forward to seeing you.
That is a great video, Katrin. It has an Auslan interpreter for deaf people and subtitles so people can read it if they want. We were really lucky to have the funding to be able to produce this video. Before we had the funds for that, though, we produced a video just like this with the same words, just using an iPhone. Do you remember that?
Oh, yes, I do. and that was actually a lot of fun to make an edit with someone like Kathy.
It was really helpful. It might have looked a bit rough around the edges, but I mention that because anyone can do that, can't they?
Yes, they can.
It's thinking through the steps and what to include, isn't it?
Yeah.
Well, what about once people are at the clinic, Katrin? What do we do then?
Well, one of our nurses will say hello to the patient of when they arrive. And just like in the video that you just saw, and we in the clinic, we have some coming in paper and some visit toys if people want something to do or entertain themselves. And just a little reminder that if you're still waiting in the for your appointment, you can get a chance of going to the bathroom that's nearby.
It's good to have toilets nearby, isn't it?
Yeah.
Yeah. All right. Okay. We also try to tell the patient if there are any delays, and we try really hard to run on time because delays can be really hard for some people. There are some things that we can't change, like how bright the lights are and sometimes how noisy and busy it is. Sometimes we might be able to find a quiet room for someone to wait if they need, but not always. We also have a routine where the nurse will take the patient, you said, into the room to have their blood pressure done. Next, though, is the appointment. How do we help that go well?
Well, our patients will all know that this doctor they're seeing when they come in to the appointment. And that doctor is usually the same one they saw last time, unless if that person has left our team. The doctor will speak slowly if the person needs it, or they might use communication cards or a communication device. But it also depends on what works best for that patient. So our nurses can give health resources to help people to understand their health as well. So we give people our website details to access health resources in easy read as well. So our nurses also offer follow-up appointments with patients and their family or support people to check if the patient has any questions after they have time to think and see how they are going.
In our Down syndrome clinic, we are trying out some different ways to run the clinic, aren't we? And you help us out in that clinic. Some of the patients at that clinic might see more than one doctor or health professional in one session. In fact, quite a few of them do sometimes. And it can get pretty confusing who they've seen and what they need to do. So we give the patient a sheet to take home about what they need to know and do after their appointment. When we know if people like this, we'll be able to do that across our clinic if it's helpful.
Yeah. When they finish their appointment, our admin officer will sort out the paperwork for their next appointment.
That's right. Our health professionals also send the person a copy of the letter that goes to their GP. We think it's really important for people to have all of the information about their health. And
that's all the things that we do here in the Mala at our clinic. And that is really important for people to feel comfortable coming to the doctor. So we are always trying to think of ways to make it better for you.
Thanks very much, Katrin. It's been wonderful to talk to you all today about person-centred care and how we really have worked to make our clinic person-centred to be able to really offer the best healthcare we can to our patients.
Absolutely.
Thank you.
Thank you, Kathy and Katrin, for that wonderful overview of your person-centred clinic. If you have any questions for our speakers, they'll all be joining us live after this next presentation. Just pop your questions in the Q&A function. Now, I'd like to introduce our second speaker, Dr. Jessica Smith, Clinical Lead for Intellectual and Developmental Disability at the Southern Adelaide Local Health Network.
Thank you very much for the invitation to present today for the Commission. My name is Jess Smith. I'm a GP and rehab physician from South Australia, and I've been asked to present today a project that we've been working on in South Australia around a person-centred care approach for people with complex disability. And I hope to outline that for you in a bit of detail today. Just like to start off with some acknowledgements from Adelaide. I'm currently speaking on the land of the Kaurna people and would like to respect their spiritual relationship with the country and elders past, present and emerging. I'd also like to acknowledge that this presentation is in the context of International Day of People with Disability, and that the theme for 2025 is fostering a disability inclusive society for advancing social progress. And we hope that we can showcase some work that we're doing to better achieve those goals today. So today I'll be speaking about the Inclusive Care Clinic, which was a research pilot that we got off the ground a couple of years ago. The Inclusive Care Clinic was really designed to be a tailored model of care, which was addressing the very large gap in access to basic healthcare for people with complex disability. And by and large, this is people with intellectual and developmental disability. And that group, around roughly 30% of this group, struggle with needle-based procedures or painful procedures that are often involved in very basic access to healthcare. So this often means, from their perspective, that blood tests, immunisations, their access to dental care is often inaccessible. And unfortunately, this contributes to very poor health outcomes for this group. It's also very difficult for health professionals to understand how they better support care for this group if they struggle to understand or have pathways in place to investigate this population and to understand how to better guide their care. If you can't take bloods for a patient, it's very difficult to understand what medical conditions you're actually dealing with and how you might better support health outcomes. So with the research pilot, we decided to develop a multi-tiered approach, a multi-tiered sensory and sedation approach. And this was largely developed around 3 tiers. And it's a multidisciplinary team that came together to test this pilot. So at the bottom of this model, you can see that we had an occupational therapist, very skilled in the care of people with intellectual and developmental disability, whose role was really to address their sensory needs. So looking at what sensory profiling was tailored to a medical procedure and how we might support some sensory adjustments in that process. And everybody in our pilot started off on tier 1 with the OT. If the OT felt that her approach wasn't going to be successful for the participant on the pilot, she then asked the team to consider sedation options. And for the 2 options that we had in this pilot, we had a light sedation tier, which we refer to as tier 2. This was nurse-led. We had 2 anaesthetic nurses who were credentialed, who did additional training and had supervision by an anaesthetist to perform light sedation in an outpatient setting. And then for those people who the anaesthetist deemed to be really in need of an anaesthetist from a safety perspective, airway perspective, we then assigned those people to what we call tier 3. So that was anaesthetist-led sedation, and the options were we either performed a deep sedation in an outpatient setting, or for those that really from a safety and comorbidity perspective needed to go to theatre, we addressed that as well. And these were the results of 16 participants that went through our pilot over a 12-month period. We did have a couple of people withdraw for various reasons. But this just identifies how successful people were with this approach. This was 16 people with an intellectual or developmental disability who had not had needle-based procedures like bloods or immunisations as an adult. Of those 16 participants, 23% were successful with an OT safe sensory approach, whether that be graduated exposure or sensory adjustments They were successful on that tier, and some of them were actually discharged back to community care. Approximately just over 38% were successful with nurse-led sedation in an outpatient department. Some of these participants used, for example, nitrous oxide through a mask, and some of them also had the addition of anxiolysis like diazepam to help them settle. Some of them also had the OT working her magic on tier 1 as well as a combined effort where the OT and nurse would work together in order to reduce the need for this person to require a deep sedation. The last group, just over 38%, did require the UNITHA for safety in terms of their sedation to successfully have either a vaccine or a blood test. Of this group, 3 patients were taken to theatre, but the remainder of patients were actually sedated in an outpatient setting, which just highlights the shift in resources when we're not taking everybody to theatre for a procedure. There were many participants who had newly diagnosed health conditions, and one participant who actually was identified as needing emergency treatment after his first blood test identified a hemoglobin of 56. But what I'd like to focus on today, given we're talking about person-centred care, is a case study that identifies how a person-centred approach needs a whole-of-system approach, not just at the clinician level, but at the system level to better, to improve health outcomes for people with disability. So today I'm going to talk about Sally, and Sally is a 33-year-old lady with an intellectual disability who participated in our pilot and has since come back to us for some ongoing care. So Sally had never had any needle-based procedures as an adult unless she was under a general anaesthetic. And she was very motivated to participate in this pilot. She wanted to visit her cousin interstate who had a newborn baby, and her cousin preferred that Sally would be immunised before visiting. So this was the goal for Sally. Sally was very determined to achieve vaccination without any sedation, but she was really quite anxious and nervous about how this would eventuate. So we commenced Sally on tier 1 with the occupational therapist. Sally attended our clinic multiple times. She actually had about 7 sessions with the occupational therapist in the lead up to her first immunisation. Sally brought a trusted caregiver with her for those sessions, and we used the caregiver in role play, and we used social stories. We talked a lot about the procedure and understanding parts of the procedure. So Sally would ask questions like, what is a vein? Why do we use the stretchy bracelet, which was the tourniquet? And we used lots of pictures and social stories to build her understanding of why the procedure had to be the way that it was and what outcomes this would mean for her health. And over time, she developed a better understanding of this. So what we did for Sally with the occupational therapist was a graduated exposure approach. And as you can see in the picture on the left, we used a Buzzy Bee, which is a distraction device, which is often used in children actually to assist with needle-based procedures. And the bee vibrates, and the backing of the bee is an ice pack, which just helps to numb the skin. What we did is we gradually introduced a BGL on the finger with the Buzzy Bee, and we worked our way up the arm until we could successfully take a BGL from the upper arm. And then once Sally was comfortable with this approach, she decided when she was ready to have an immunisation. She had a little bit of diazepam just to settle her anxiety, and she was successful and actually came back to have several immunisations with us. A really important part in this process was the certificates that the occupational therapist provided for Sally, and this just helped build her confidence and really built momentum for her to then ask us whether we could take bloods for her. We did try a couple of times to take bloods for Sally, but she really struggled with the time required and the skill that's needed to take bloods and the process itself. So Sally requested that she move to the next tier and have sedation. And what we found was that Sally actually, with the next round of attempts, was quite successful, having her bloods taken with some nitrous and diazepam. This is a really good example of what has eventuated to be a shared care approach for Sally. So Sally now continues to have immunisations and some injectable medicines like a depot with her general practitioner, but she returns to the inclusive care clinic when she needs blood tests or an iron infusion if needed. So what does person-centred design mean for us when we built this model of care and piloted it? And really, there's a couple of aspects to this. So at the clinician level, we really need to meet people where they're at in terms of healthcare, and an exploration of the least restrictive approach, first and foremost, is very important to us. And that takes time. So often we're looking at, from a clinician perspective, what is the person's sensory needs? What medical trauma have they experienced in the past that makes this experience really difficult? What do we need to consider from an environmental perspective? People become very distressed and have had a lot of negative experiences in the hospital system or even in primary care clinical settings. And this really needs to be factored in, including a trauma-informed approach to care. So I think really at the outset, we need to really shift our expectation that people with disability only ever receive care within a clinic or hospital-based setting, because they're often a lot more comfortable in their home setting, and some of these procedures can successfully occur in the home or somewhere where they feel comfortable, somewhere where we're taking the pressure off them, that they might be more successful in having access to basic healthcare. We also need to think about how we communicate with people, and we need to better explore their understanding of the procedure itself and why the procedure does hurt, and we are hurting them at times, but what that means for their overall healthcare. So for Sally, using things like social stories and easy read documents and spending the time to answer her questions set her on a journey to have a positive experience, and we celebrated those achievements along the way. And Sally, now been successful in community care, has been a great outcome. And we've also had other participants through the pilot who we thought would need quite deep sedation initially when we started working with them, who have surprised us and been successful having immunisations and blood tests without any sedation at all. What does this experience tell us around person-centred care at a system level? And I think this is the bigger conversation that we need to have. Is not just all about what the clinician can do at the forefront, but how do we actually design better systems or better models of care to support people with disability. And Sally's a really good example of the need for a more integrated model of care for people with disability. Not all primary care can be done in primary care for people with complex disability, and we need to understand and develop pathways that support the patient in accessing some procedures that might need to be done in a tertiary setting, for example, those procedures that would need sedation, and also the health professional. So building these pathways would better equip general practitioners and primary care health professionals in supporting people with disability when they know they've got another resource to call on. At a system level, we need to understand that the problem is actually quite large. So if we look at people with intellectual disability, around they have double the rates of preventable deaths compared to the general population. And they have a large gap in life expectancy, about 27 years less than the general population. If we were to look at the numbers of people with intellectual disability alone who struggle with needle-based procedures, based on some data from about a decade ago, we would be looking at over 200,000 people with just intellectual disability who would need support with needle-based procedures. So we really need to develop models of care that cater to greater volumes of people, not just people with intellectual disability, but people with other cognitive and sensory disabilities that need support with needle-based procedures. And this leads us to a bigger conversation around what has been difficult for those clinicians on the front line for some years around building models of care like this, and the complexity around decision makers who make decisions around the risk of sedation. But what we see from the clinical frontline is the risk of doing nothing at all. And that's a bigger conversation that I think we all need to have. I think it will involve us to be a little bit more courageous and take some risks. Because if we were purely to design supporting this population with anaesthetic-led theatre models of care, it would be very expensive, and it really caters to very few people. So I think we need to be a little bit bold. We need to test our ideas and have a room to do so. Really, what we need to build is bespoke models of care that look at multidisciplinary disability teams that involve allied health professionals, diversional therapists, nurses who are skilled and credentialed in nurse-led sedation, and consider our approaches beyond the hospital environment for people who might be able to have procedures in their own home without the need for sedation. And for many people, this approach and this person-centered approach can really rebuild their ability to engage in community-based care. Thank you.
Thank you, Dr. Jessica Smith, for that insightful presentation, demonstrating how working through some of the important detail at an early stage can help to ensure that healthcare can be provided in a way that is more inclusive and in a way that can result in a better experience for people. So welcome everybody to our live Q&A as part of this webinar on International Day of People with Disability. Now I'd like to introduce you to our panelists. So you've already met Dr. Kathy Franklin and Katrin Culler, as well as Dr. Jessica Smith. But I'm also joined by Ricky Kremer, who is the Lived Experience Inclusion Lead, and Professor Julian Troller, AM, from the National Centre of Excellence in Intellectual Disability Health. So thank you all very much for joining us today. If anyone has any questions watching us live, please put them through the Q&A function. We'll get to as many questions as we can. If we don't get to them all now, we'll try and send you some answers when we send the recording of the webinar around afterwards. Okay, so let's get to it. First question we have here, Ricky, I'm going to give this question to you. Thank you so much for joining us today. Most of the people that will be listening to this webinar will be from general health services and not specialist services. So what sort of actions do you think that they could make to make people with intellectual disability feel safe when they're using health services?
I think in terms of making them feel safe, I think communication is really key. I think that the medical professional and the person with disability or intellectual disability really communicate what they need to feel comfortable, but also the medical professional putting in place things like if they have a session with them, if they find it getting a bit of anxiety waiting too long for their appointment, I think just maybe notifying the patient that they might be a bit longer or to come in at a certain time where they can just come and go straight into that appointment is really, I think, is one of the key things. And mainly just to ensure that the patient is happy while they are in the waiting room is another example as well.
Thanks, Ricky. It's they seem like small things, but they make a really big difference, don't they? And I'm going to ask this question also to Katrin. And one thing I loved about your video was the bit about the parking. I know that I have often wanted some better detail on parking when I've been going to a health appointment. So I think that that's a universal thing we can learn from your video. Katrin, are there any other tips that you have that make you feel safe when you're visiting health services?
Well, the reason why we did the video is because the reason why we did the video the way we did is because it's helping people to know what's going to happen when they come in, and that's why we made the video the way we did, so that we can so if people do feel lost coming into the city or coming into the mala, this video will actually show those people of what happens at the clinic and of how to get there. It might be tricky, but if I based on my personal perspective, coming from someone who's got Down syndrome herself, and you have a health professional respects you can actually trust that the staff, the health professionals are actually here to help you to actually fully have your trust in them, so that the professionals have trust in you. And for myself specifically, having disability myself, you can have staff and professionals that actually care about you as a person, not as a person of who you are, and not be judged by your own disability.
Yeah, thanks, Katrin. Building that trust is very, very important.
Absolutely.
Julian, you've been running the National Centre of Excellence for a couple of years now. What are the top 3 things that you would like to see change in healthcare delivery?
Oh, thank you, Anna. And just before I answer, could I just acknowledge I'm in the land of the Bidjigal people here at UNSW Sydney, and I'd like to pay my respects to elders past and present, and Aboriginal and Torres Strait Islander people here today, and of course acknowledge the significance of intellectual disability for community, and acknowledge people with lived experience of disability and those who support them, and the leadership by people with intellectual disability in the work of the centre. This is a great opportunity today, being International Day for People with Disability, for us to think together, those in the who are listening and watching, those on the panel, about really what makes inclusive healthcare for people with intellectual disability. From the centre's perspective, we've been doing a lot of deep thinking about this. For me, one of the first things I think is making sure that people with intellectual and developmental disability, when they hit a health service, encounter a health professional who's been trained to deliver that accessible health care that's person-centred. Now, this is a shift from having a few people equipped in that area to making sure that all current and future health professionals have this skill and knowledge, and that that's informed by a co-designed and co-delivered teaching approach by people with disability. Second, I think, is making sure that we've got availability of appropriate models of care and funding base that actually supports implementation at a widespread or big scale, whether that's in primary care, whether it's in hospital or more specialised care or emergency care. At the moment, we've heard of great examples through the work of Jess, Katrin, Kathy, of what is possible in this space, but really the available services are a drop in the ocean compared to what is actually required. And third, I think, is making sure we've got a system which has a much more inclusive culture than is currently the case, in which people with intellectual and developmental disability are empowered in clinical settings to actually have collaborative conversations with their healthcare provider and provide real advice on how to improve practice as it goes. I think if we have such a positive culture in our system and permission to have those hard discussions and empower people with intellectual disability to lead those discussions, that to me would really help.
Excellent. Thank you, Julian. Kathy, it's clear that when patients come into your clinic, they have an amazing experience. What do you see happen when they're transferred to other clinics or settings?
Oh, look, I think I'm always mindful. So we had many years of having a small clinic in a suboptimal environment, and it certainly wasn't always as glossy and glamorous as that video looks now, right? I think, and so look, yes, people can have challenges in various settings. What I think I hear and have found over the years, though, is that the attitude of the healthcare staff is almost or just as important as what they know how to do. So even if it's another stressful, busy setting, if the person who's running the neurology outpatient clinic is caring and can think about what the person needs, then it goes okay. And so, yeah, I think those are the things that really help in those other settings. I am pleased that people actually do have to come to a hospital to see us, because it helps them have a pleasant experience first as well, coming to hospital. And that's really helpful, because a lot of people have suffered a lot of trauma attending hospital appointments and in hospital and healthcare settings. So sometimes there's a lot of trauma to deal with for the person. And so that's the thinking, keeping that in mind when people are entering the building is another important thing, I think.
Yeah, definitely. Jessica, a similar sort of question. I really liked your phrase, meet people where they are at. What do you think that general healthcare can learn from that approach?
Yeah, thanks, Anna. Actually, I was just reflecting on some of these adjustments that the panel are referring to today, and I think that's probably what those of us do on a daily basis who have a bit more experience in adjusting our approach to providing healthcare for people with disability. But I think at the outset, as Julian mentioned, if we could actually train health professionals to do this from the get-go, it would set the whole system up to be a bit more successful, because it can't just rely on a few individuals. And the way that the health system operates at the moment is very one-dimensional in its approach. So essentially, the person needs to fit into the way that the system operates for them to actually have care a lot of the time. And that's very difficult for people with disability to understand that process. It's a pretty fast-paced process as well, the health system, and it's unfortunately often squeezes people out with complex needs who might need a different approach. But I think at the outset, what we're hearing today is that often this is considered by a health professional if the person can't participate in the care in the way that the health professional expects. Sometimes they conclude that it's not possible. But what we're showing here today is that even just small adjustments, increasing the time for an appointment, seeing someone in the car park, understanding that we might have to change our language and way of communicating, actually often can set up the appointment or consultation to be successful.
Yeah, thanks. And Ricky, you spoke about communication. Have you got any tips on, we've spoken about quite a lot of different adjustments and options. Have you got any other tips on better ways of communicating?
Yeah, I think in terms of communicating, things like using everyday language, like you would be talking to, sometimes just talk to a friend, really directing directing all the questions and things to the patient, even if they have a support worker in the office, so that making sure that they clearly understand what's going on, particularly with if there's any new medication that they might be taking, and really explain how to go about using that. And I think if there's any kind of documents or information that they want to give that patient, to make sure that it's very simple, plain language, so that not only is it understood by the patient, but understood by anyone that's supporting them along the way.
Yeah, good tips. Good tips. Katrin, do you have any more tips on good ways to communicate?
Well, there's a lot of things, to be honest. The way you approach them, you got to try to give them your full attention, your full support, give them full respect. The most important thing is you don't rush them to have that communication. You got to give them the time that they want. Or in other cases, to get to know who the person is, of how they want to communicate. Because here in the Mala, we have like tools that we use to help people if they're verbal or non-verbal. It doesn't have to be their own tablet of their own. You can also give them other tools they can use. If they're got Down syndrome, if they're autistic, if they're non-verbal or verbal, if they're in a wheelchair or whatever, they have you can give them a certain tool that they can that they can use to help their way to communicate with you, so professionals can understand the way they communicate towards you.
That's great, thank you. You might get a few people contacting you after this to ask about those tools. So I'll pass on your email address to them.
And you can pass on Kathy's email actually.
Okay. Julian, have you got any tips for how we can better involve patients and families in decisions about healthcare?
Look, I think there's lots we could do. I think thinking about the theme of inclusive healthcare today, I think with some notable exceptions at the moment, I don't think we have the right kind of high-level leadership that ensures the right settings in healthcare delivery that make services accessible and person-centred. I know and acknowledge that the Centre and the Commission have done lots of work thinking about this and doing things about it. I think the Commission's Standards User Guide for Health of People with Intellectual Disabilities is one great example, and the resources that you've developed. But I do think a key step is that leadership in services, and that needs to extend to involving people with intellectual disability and those who support them as part of organisational planning and review of services. And I think then that has a flow-on effect that it means that staff eventually get the training and support they need to make adjustments in routine clinical practice. There are some simple things we can be thinking about for the future. There's some great work being undertaken by Rima Harrison from Macquarie University and colleagues developing PRIMS and PROMs. These, I guess, will help us know what the experience and outcomes are for people with intellectual disability in our systems. And we need to be thinking about that cycle of quality services and quality improvement. But I do value the leadership of many in this area, but I think we can do that leadership aspect somewhat better.
Yeah, thanks, Julian. Jessica, I've got a question that's specifically around your work. Has anything been done with people with disability on new non-needle alternatives, such as nasal spray, vaccines, to see how they're tolerated?
I have the exact same question, actually, Anna. So I think it's a wonderful question. I have recently been interested in some of those vaccines coming out to children, and have that on my to-do list to look up to see whether they have been, whether there's a guideline to be used in adults, because that would be appropriate for many of my patients that I see. The challenge with this often is that a lot of the research that is done to develop guidelines for patient care doesn't actually include people with intellectual and developmental disability a lot of the time. And that makes it very hard for some of us to guide care around that. But I think it's a really great question, and one that certainly some of us have some interest in.
Yeah, maybe a future webinar, I think.
Yes, absolutely.
Okay, this is an interesting question. Possibly, well, anyone can answer it if they've got a good response. If you think you're caring for somebody that might have an intellectual disability, but it hasn't been explored, what are good tips for bringing this up with the patient, and what might the next steps be? Anyone clear Anyone's keen to tackle that one? Kathy?
I'll have a go.
Go
Shall I
ahead.
have a go?
Go ahead, no, step out.
So look, I think so. The question is around someone that you're caring for, and intellectual disability are very foreign words, and so really what we're talking about is trying to find out if the person has any issues or might need some extra help, and if they're having any difficulties that people might be able to help with, right? So it's I would focus more on how things might be able to help. One of the parts of the question was then what to do about that. And I think talking to their GP is a good place to start, but then the GP might be like, oh, I don't know what to do. If the GP thinks, so if we're thinking if someone might have an intellectual disability, some of the things we might think about was what happened when they went to school. Did they need to go to a special school? Did they need extra support at school? That's not universal, but that sometimes can be a good guide. And if there might be some thoughts around that, then it might be important for them to be able to access some testing and to take that further. And that's kind of different depending where people are. Yeah. But yeah, that's the first way. But I also say the GP because it's important if people are thinking that there's some physical health things to think about as well, to rule out.
Thanks, Kathy.
Could I just also mention, I think important we think about cultural elements in relation to use of labels or acceptability of diagnoses, particularly for First Nations communities where the understanding is very different and inclusion is done completely differently and is a strength. And for some culturally and linguistically diverse communities for whom there's substantial stigma or shame associated with a diagnosis. So I think there's that concern, and obviously the strength of our relationship with the person also has a bearing on what we say and when we say it, and how we might be able to do that respectfully and explore that for the person, with the person.
Thanks, Julian. So the title of today's webinar was Building Inclusive Healthcare. I've been jotting down some words as we've been talking about what inclusive healthcare seems to mean to people. So I've jotted down respect. Katrin, you've said respect a number of times. It's a very important part of inclusive healthcare. Communication and empowerment. I think empowerment is a really important one. I was just wondering if we can go around the panelists, if there's one word that they can think of that sort of sums up inclusive healthcare. It can be one that we've already said today or one that we've missed. I'll start with Jess.
Oh, thanks, Anna. There's many, but I like to give people options in the way that I provide care, and when it's clinically appropriate to do so, build trust and rapport at their pace and allow the person to drive a lot of the way that we use the tools that we use as doctors and get better outcomes that way. Choice and options.
Yeah, options and trust, I think, definitely. Julian.
Could I use the word valuing? Valuing the person as an equal citizen with rights to access to quality healthcare. So I think for me, valuing comes to the societal shift that we need to understand the experience of people with intellectual disability currently and to radically change that.
Thanks. Ricky?
I would say respect, in particular when someone is describing their symptoms, to be actually taken seriously and not be brushed off just because they've got an intellectual disability. So I think that's very important.
Yeah, thank you, Ricky. Kathy, and then we'll go to Katrin.
Well, I was going to say respect, because I do like the way that respect includes valuing, but also talks about, it speaks to the importance of the person. But I think another word I will choose then is care, which might be unusual, but I like the word care. We talk about care a lot because we say
do.
healthcare a lot.
Yes, we do.
But the word care really is broader than that, and it's not just respecting someone. It's caring what happens. It's caring that they get the services and the treatment that they need. So I think care will be my word. What's your word going to be?
Like mine will be per se, treating them with fair, treating them as an equal, like treating them fairly and equally.
Mm-hmm.
And I'm gonna say this once, because inclusiveness means, for me personally, because I've had experience with it, to my own experience, it means something. I have a certain saying in my words. I got this from my own high school. Say the right thing, engage in the learning, treat others with respect, owning your own behavior, and never give up was a saying that I had in my high school. And at the moment, my high school's been shut down, and that requires people with special needs, if it's anyone in a wheelchair, anyone that's got a disability, to be treated well, especially in learning. If you're not to engage in the learning, to have an indication of what's going to happen to you in the future, and to see that all stripped away, it's heartbreaking.
So what's your word then? You had a lot of words then.
I have a lot of words, because I have a lot of heart to people with disabilities, because coming from my own experience.
Well, you said heart, you said respect.
Yeah, heart, respect. If I say love, it's the main top word that I will use.
Okay, thank you.
That was perfect. And I've been writing down all of those words, Catherine, so they're not lost here. And I think a word we've been talking about a lot lately is compassion, which I think is quite similar to love. But I think you summed up inclusivity perfectly there. Okay, so I'm conscious of the time, so we're going to have to wrap it up there. But I'd really like to thank all of our participants today, including our interpreters that have been helping us out. You've made this a really valuable webinar. Hopefully we've given you some practical ideas about how you can make healthcare more inclusive and more person-centered, a more person-centered approach. Don't forget to sign up to our newsletter, which is due out next week. This also has a spotlight on disability. And we will also be sending out the recording of this webinar. Any more questions that you want to send through, please send them through, and I'll send them on to our panelists, and we'll include the answers with the recording. But thank you again to all of our panelists. I think this has been a really good International Day of Disability. So thanks again.